Greetings, everyone, and welcome to the third event in our inaugural Fall Symposium series, the Veteran and Family Wellbeing Series, a person-centered, evidence-based approach to chronic pain. Bonjour tout le monde et bienvenue au troisième événement de notre série inaugurale de symposium de l'automne. Série sur le bien-être des vétérans et de leurs familles. Une approche de gestion de la douleur chronique basée sur les données probantes et centrée sur la personne. I am Dr. Mme Patricia, Chief Executive Officer and Medical Director for the Chronic Pain Center of Excellence. At the Center of Excellence, our mission is to improve the well-being of our Canadian Armed Forces veterans and their families suffering from chronic pain. Je suis le Dr. Mme Patricia, chef de la direction et directeur médical du Centre d'Excellence sur la douleur chronique. Au Centre d'Excellence, notre mission est d'améliorer le bien-être des vétérans de nos forces armées canadiennes souffrant de douleurs chroniques et de leurs familles. Merci à tous de vous joindre à nous aujourd'hui. Maintenant, je vais laisser la parole à nos modérateurs, le général Michel Maisonneuve et général Eric B. Schoolmaker. Thank you all for joining us today. I will now pass it over to our moderators, General Michel Maisonneuve and General Eric B. Schoolmaker.
Bonjour, chers amis. Voici un message spécial de Alex DeBrincat, joueur de hockey des Blackhawks de Chicago. And now, a special message from Chicago Blackhawks hockey star Alex DeBrincat.
Hi everyone, I'm Alex DeBrincat of the Chicago Blackhawks. I'm honored to be a part of today's event led by the Chronic Pain Center of Excellence, in collaboration with the U.S. Department of Veterans Affairs and the U.S. Department of Defense. As a hockey player and an athlete, we all experience chronic pain to some degree throughout our careers and even once we've hung up the skates. Mental and physical pains can be unbearable to deal with, and that's why I train both my mind and my body to get stronger and better every day. As a proud American, I've been fortunate enough to grow up and live in a country with all the freedoms and opportunities in the world, and it's because of the commitment and service of our veterans that I'm able to play the game I love every day. Thank you for your service.
Good morning and welcome to this very special webinar aimed at sharing our collective experience, our wisdom, and the many questions that remain about how to best care for our Canadian and U.S. service members, veterans, and families with chronic pain. I want to thank Dr. Ramesh Zacharias and his colleagues at the Chronic Pain Center of Excellence at McMaster University for the invitation to be with you today, and for the Wasserman team in producing these series. A shout out to our special guests in the NHL who remind us that professional and other athletes have a major burden of pain through which they must work to achieve optimal function. Their support is very much appreciated. I'm Lieutenant General and Dr. Eric Schoolmaker. I was privileged to serve as the former U.S. Army Surgeon General and the Commanding General of the United States Army's Medical Command. I have a passion and an enduring commitment to help those who are suffering from pain, especially those who have served in uniform in all eras to defend our two nations. I'm privileged to serve as the co-moderator for today's unique international forum, the third, as you've heard from Dr. Zacharias, of this four-part series from the Chronic Pain Center of Excellence. You can best join us by signing up via the information box on our website, by asking questions via the information box that's on the right-hand side of your screen, by viewing us in the full screen mode, and then by using closed captions if you're among our French-speaking audience. Now over to a trusted colleague, Lieutenant General Michel Maisonneuve.
Merci beaucoup, Eric. Mon nom est Michel Maisonneuve et je suis un vétéran de l'armée canadienne dans laquelle j'ai passé 35 ans. Je suis honoré aujourd'hui, avec mon collègue, le lieutenant-général Schoolmaker, de servir comme modérateur de ce webinaire. My name is Michel Maisonneuve, and I'm a veteran of 35 years in the Canadian Army. Many veterans suffer from chronic pain as a result of their military service. For them, it's a constant in their lives. So it's my honor today, alongside my American colleague, Lieutenant General Schoolmaker, to help moderate this third of a series of webinars dedicated to helping veterans who suffer from chronic pain. Today, our webinar will follow a bit of a different format from the previous two. We will have 3 separate presentations, which will be followed by a panel discussion and answers to your questions. Notre webinaire aujourd'hui suivra un format un peu différent des 2 autres. Nous écouterons 3 présentations et suivrons avec une discussion en panel où nous répondrons à vos questions. Je vous demande, si vous ne l'avez pas déjà fait, de vous inscrire dans le panneau à droite et vous pouvez poser vos questions de la même manière. Ensuite, il est plus facile de visionner le webinaire en mode plein écran et pour voir les sous-titres en français, il suffit d'activer le mode closed captioning ou sous-titrage codé, l'icône CC au bas de votre écran. Alors, allons-y. Notre première présentation sera effectuée par la Dr Patricia Poulin, qui est psychologue clinicienne et experte en réhabilitation à l'hôpital d'Ottawa. Elle s'intéresse particulièrement au traitement multidisciplinaire pour la douleur chronique. Sa présentation traitera de la méthode de traitement par étapes. Elle expliquera le processus par lequel le vétéran pourra recevoir des soins de plus en plus intensifs liés à sa douleur et aussi la version 2.0 de cette approche par étapes. Dr Poulin, à vous.
Good morning, everybody. It's a pleasure to be here with you today, and I want to thank the leadership of the Chronic Pain Center of Excellence for Canadian Veterans for the invitation to speak with you about Stepped Care 2.0 for chronic pain. I want to start by a territory acknowledgement and just acknowledging that the land I'm standing on and sharing this knowledge from today is the traditional and unceded territory of the Algonquin Nation. And I would like to invite you to do the same and just acknowledge the land that you're standing on, listening to this presentation today, wherever you are throughout the country. The objective of this talk is to first describe 2 major framework that we can categorize stepped care approaches under. Then to describe Stepped Care 2.0, I'll go quite a bit more in depth into the stepped care approach that we use at the Ottawa Hospital. And then to discuss the application of stepped care 2.0 principles to chronic pain recovery through actually a case study. Now, in terms of making it your own, as a veteran, a family member, a clinician, or a health administrator, I think that's really a lifelong journey where we can never stop learning. It takes a lot of self-reflection, monitoring, adjustments, refining, evaluation, and then trying it again. Let's get started. So stepped care for chronic pain. So what does it mean, stepped care? So stepped care, in a nutshell, means using interventions that vary in intensity, time commitment, efforts, and resources needed to meet the needs of people living with chronic pain who are seeking our care. There are really 2 major umbrella or categories of stepped care approaches. There are progressive models where everyone will start with lower intensity interventions and then progress to higher level intensity interventions if they fail to make progress with the lower treatment intensities. There's also matching or stratified models where somebody will have a more comprehensive assessments right from the get-go, and then if they have mild symptoms, they'll be directed to lower intensity treatments. If they have moderate symptoms, to moderate intensity services, and then if they have severe symptoms, to really acute and more higher intensity interventions and treatments. Stepped Care 2.0 is a little bit of a mix of both. It's a flexible, progressive stepped care approach. And at the practice level, it's a systematic and flexible approach or system to address the client's mental health and chronic pain needs, taking into account their goals, their preference, their needs, and their readiness. It's very important to start from a person's goal and readiness, because even if somebody might have very severe symptoms, they might not actually be ready to engage in more intensive treatment. And Stepped Care 2.0 is also anchored into recovery principles, which actually I will speak about briefly in a minute. And it favors solution-focused and strength-based, lower intensity interventions whenever that's possible. That being said, it does not prevent access to higher intensity treatments if that's what's going to meet the person's goal, and if the person is ready to work hard. And the way that we make decisions on stepping up or stepping down treatment is through the use of continuous outcome monitoring, where every now and then at regular interval, we ask the person to complete some self-assessment to help orient the next phase of their treatments. Now, I've talked about Step Care 2.0 at the practice level, but for health administrators at the system level, it's really about coming together with people with lived experience, clinicians, researchers, to transform our health system by developing, delivering, monitoring, and adjusting the programs that we have to better meet the needs of all people who live with chronic pain. So not just the people who can and have the tolerance to complete an 80-hour intensive program, not just people who will respond to interventional management, but really for everybody. So with Step Care 2.0, there are really 9 levels of care. Somebody might just at first benefit from learning more about chronic pain, having some information about the difference between acute and chronic pain and best approaches in their management. Somebody might be actually ready to start taking some online courses at their own rhythm and to see what they can learn really on their own. But somebody might actually be interested in meeting other people that have lived experience of chronic pain and learn from their experience. And there are many peer-led self-management programs across the country that people can access. Someone might instead want to take on participating in some workshops that are delivered by a clinician who's been studying and working in the area of chronic pain for a long time. Somebody may feel like, hey, I'm doing this self-management course online on my own, but I need a little bit of help. I need some troubleshooting. And then you can actually schedule 5-minute, 10-minute, 15-minute coaching session in order to help troubleshoot whatever issue is coming up, maybe with pacing, with energy conservation, with making some, implementing mindfulness strategies, or any questions a person may have. Then if somebody is really struggling with something specific, they're ready to get into it, they might be able to participate in group therapy for specific concerns, and I'll share about some of the groups that we offer at the pain clinic. Or they may be ready to participate into a more intensive interprofessional chronic pain rehab program, and we have a few of those available throughout the country. And finally, in terms of the 2 last steps, if they need one-on-one treatment, then that can be scheduled in. And if they're really struggling with managing day-to-day activity, with keeping straight all of these appointments, assessments, they might actually benefit from a case manager who will help them navigate this and access not only the healthcare system, but also community resources in order to better achieve their goals. And in a nutshell, all of this is really to help people fill this pain management toolkit to really make it personal. And I know that you've already had some sessions on the biopsychosocial approach and whole person care for chronic pain, so I will not get into it, but it's very much connected. So just to give an idea of the offering at our pain clinic, we have workshop on assertive communication, on managing stress and anxiety, on pain and trauma, very relevant for people in the audience, veterans who may have been exposed to or experienced trauma, who may be experiencing post-traumatic stress disorder. We have workshops on financial resources, financial literacy, on mindfulness, how to talk to your family, to your healthcare provider, and we have workshop on how to support somebody who lives with chronic pain. Some of the groups that we offer, for example, we have cognitive behavioral therapy for depression and anxiety. We know that is often co-occurring with chronic pain. We have a mindfulness-based pain management course. We have a kind of behavioral therapy for insomnia, and our social worker runs a number of different support groups and discussion groups. I mentioned earlier that recovery principles are really central to step care, and I will just share with you 2 models. And in a nutshell, there are so many dimensions of recovery, but it's very important to consider that recovery from a chronic pain perspective is a lifelong journey. There's not just one size fits all, and there are many pathways. It's important to feel like there's hope. And I hope that over the next little few minutes, when I share the case study, that you will also feel that if you're struggling with pain. It addresses trauma, it takes into account the whole person, their relationship, and really leverages the experience of people with lived experience as key member of healthcare teams, actually, and of a person's recovery. I'll invite you just to consult these two documents if you're interested in knowing more about recovery. Now I'm going to dive into a case study. So this is fictitious, but it's very, very realistic. This is very representative of people that we work with at our pain clinic day in, day out. So Richard is a veteran who was injured in a motor vehicle accident while deployed overseas. He's paraplegic with severe chronic neuropathic pain in both of his legs. He was seen in another pain clinic 7 years ago. That clinic was predominantly doing interventional management, and he failed to respond to all treatments, unfortunately. Infusions, injections, spinal cord stimulation, he's still having quite a bit of pain. So at the time that Richard is actually being referred to our clinic, he's on 290 milligram of morphine equivalent daily. But despite the fact that he's struggling with his pain on a daily basis, 8 out of 10 to 12 out of 10 pain, he's really pushing himself to be active, in line to participating to Paralympics, and he is also really pushing himself to be present to his family. But this is not the life he wants for himself or his family. So before before the implementation of Step Care 2.0, if Richard had been referred to our clinic, he would have been seen by a physician first, and he would have been waiting for 2 years actually between the time of his referral to the medical visit. Then he would have been referred to either psychology, occupational therapy, physiotherapy, social work, or to our intensive 80-hour chronic pain management rehab program. And for that, he would have had to wait another 6 months. After we implemented Step Care 2.0, as soon as Richard would have been referred to our pain clinic pre-COVID, he would have actually been invited to participate in an orientation and education session where he would have learned about a lot of resources he could access right away to help manage his pain. Now, post-COVID, our wait is about 3 to 4 months. Then he would have seen his physician, and then he would be referred to our interprofessional team for a group intake where we go more in depth into chronic pain and its management. We go over all of the programming that's available. And the good news about this is that Richard does not wait between his medical visit. If he's referred to our interprofessional team today, he's scheduled into that session next week. And then he gets to meet one-on-one with a member of our team and to make a personalized treatment plan. And again, for that, there's no wait. Next week, he meets, he goes into his group intake. The following week, one-on-one personalized treatment plan. And this is what we learned from Richard. So his goal is to reduce his reliance on medication, improve his sleep, sleeping 3 to 4 hours a night, very broken up sleep, and reduce the number of days off due to pain crises. In his meeting with a therapist, he tells more of his story. He's really caught into a push-crash cycle. When he's doing a bit better, he just push to do as much as possible, and then he crashes for 3 days. A lot of self-loading went down. He's not coping well, sometimes using his medication and alcohol. Anxiety is present. Is a previous diagnosis of PTSD, but he doesn't feel it's much of an issue. He responded well to treatment, and service dog was super helpful. So this is what his treatment looks like at our clinic. Might look like at our clinic. So first, he's invited for participating in a sleep workshop and a pacing workshop. Let's get some strategies right under his belt. And then he participates into our 4-week distress tolerance and emotion regulation skills group. Once he's got this foundation, he comes into our 20-hour chronic pain rehab program. He declined the intensive. It was not quite the right fit for him. In phase 3, sleep is still an issue. He's improved in terms of his ability to pace, his ability to manage pain. His actually reliance on medication, PRNs, has reduced, but he wants to get into his sleep issue. He participates in our 4-week cognitive behavioral therapy for insomnia. And there, during that treatment, he learns about mindfulness a bit more and wants to participate in our 8-week mindfulness pain management. So he's, can go into it right after he finishes the CBT program. Afterwards, Richard is actually feeling quite a bit better. He's had his appointment with his physician, with the members of our team, and we're looking at how do we maintain those gains. In phase 5, he basically decides that he's going to enroll in our drop-in online mindfulness session. He's invited to do that, to drop in anytime he wants on a weekly basis. So our goal with this approach is really to eliminate wait time, to make everybody feel welcome. There is something for everyone in our clinic. And because we use group intensively, people really have a sense that they're not alone. Our treatments are adaptable, flexible, they give people choice, and they really target the whole person. Our goal is really to make people feel really empowered and feel like they have the tool to continue to manage and live their lives well with chronic pain. On that note, I'll thank you again for being here today, participating, for your service, if you're a vet in the audience, and just want to acknowledge the team in the Ottawa Hospital and the Ontario Ministry of Health for their funding and support and contribution. Thank you.
Alors, merci beaucoup, Patricia, pour cette excellente présentation et votre cas qui illustre bien l'expérience de nos vétérans. Une des leçons qui est ressortie de tous nos webinaires est l'importance d'une approche multidisciplinaire qui est axée individuellement envers le vétéran. La méthode par étapes est une excellente façon de mettre cette approche en place. Comme expliqué par le Dr Poulin, le modèle 2.0 ajoute encore plus d'outils et d'étapes pour le traitement. Notre prochaine présentation donnera d'autres détails sur cet aspect avec le témoignage d'un vétéran. A multidisciplinary approach to treating chronic pain is very important, and the stepped care approach is a good way to implement this care. As presented by Dr. Poulin, Stepped Care 2.0 adds more steps and tools for the treatment of pain. And the next presentation will provide more details on this aspect. Notre deuxième présentation sera offerte par Mme Regina Visca. Ms. Visca is the Administrative Director of the McGill Ruiz Center of Expertise in Chronic Pain. En tant qu'employée civile de la Défense nationale du Canada, Mme Visca a travaillé sur le projet des frégates de patrouille pour la Marine royale canadienne, où elle a appris l'importance du travail en équipe vouée à une mission, ce qu'elle applique aujourd'hui au traitement et la réhabilitation de nos vétérans. Mme Visca dirige actuellement le Centre d'expertise sur la douleur chronique de l'Université McGill à Montréal. Elle sera accompagnée par un vétéran de la Marine, Derek Spears, blessé durant l'incendie du sous-marin NCSM Chicoutimi. Derek nous témoignera de ses expériences avec la douleur chronique et le traitement par étapes. Ms. Visca and Derek Spears, a Royal Canadian Navy veteran, will provide more details and personal experiences in the use of step care for the treatment of pain. Regina, over to you.
Bonjour à tous. Derek et moi avons le plaisir aujourd'hui de vous présenter le Stepped Care Model pour la gestion de la douleur. L'objectif de la présentation aujourd'hui est de vous présenter le modèle Stepped Care et de décrire comment le réseau universitaire de santé et de services sociaux de l'Université McGill a implanté ce modèle. On aura également l'opportunité d'entendre la perspective d'un vétéran. Le réseau universitaire intégré de santé et de services sociaux de l'Université de McGill couvre un vaste territoire géographique et dessert les anciens combattants souffrant de douleurs chroniques qui vivent partout au Québec. Nous avons basé notre approche de Stepped Care sur les recommandations du Pain Task Force canadien et American Pain Task Force, qui comprend dans les deux cas le département de la Défense et le département des anciens combattants. Ces deux groupes de travail recommandent une approche biopsychosociale de la prise en charge de la douleur, fondée sur des preuves scientifiques qui intègrent la multimodalité et l'interdisciplinarité, tout en étant adaptée aux besoins, aux préférences, aux croyances et aux valeurs de chaque individu souffrant de douleurs chroniques. Derek, quelle a été votre expérience de vie avec la douleur chronique? Comment a-t-elle commencé et comment a-t-elle affecté votre vie?
Bonjour Regina, merci beaucoup de m'avoir. C'est un plaisir d'être ici avec vous. Moi, j'ai servi dans la Marine canadienne pendant 22 ans et aussi dans les sous-marins de la Marine canadienne. En 2004, j'ai ramené un sous-marin de l'Angleterre et qui a eu un accident et un feu à bord. Suite à ça, en 2006, j'ai eu des crises épileptiques et durant une de mes crises, je me suis fracturé le dos à 5 endroits. Ça a été le début de mon voyage en douleur chronique. Suite à ça, aujourd'hui, j'ai eu des opérations dans le dos et je vis tous les jours avec la douleur chronique. Mais ça m'affecte tous les jours, mais je suis ici aujourd'hui pour vous dire qu'il y a de l'espoir.
Afin de répondre à la nature multidimensionnelle de la douleur, le modèle Stepped Care préconise une approche individualisée de la gestion de la douleur, comprenant 3 composantes. Chaque étape intégrant des évaluations de la douleur et des plans de soins interdisciplinaires fondés sur des données probantes dans le but de permettre aux patients de retrouver leur fonction et d'améliorer leur santé et leur bien-être. La première étape met l'accent sur le rôle du clinicien des soins primaires dans l'identification et la discussion des problèmes de douleur et dans l'élaboration d'un plan de traitement axé sur l'éducation et l'autogestion. Les personnes qui vivent avec la douleur et leurs familles ont accès à l'éducation concernant certains principes de base sur la gestion de la douleur, comme les effets indésirables des médicaments, l'importance du sommeil, une nutrition adéquate et l'activité physique. Les approches d'autogestion offrent des stratégies individuelles axées sur la modification des facteurs cognitifs. Des physiothérapeutes ou des kinésiologues sont à leur disposition pour les aider à faire de l'exercice avec la douleur chronique, tandis que les psychologues et les infirmières les aident à gérer le sommeil, l'humour et le fonctionnement. Et les pharmaciens optimisent la médication. Nous disposons de cliniques interdisciplinaires de première ligne de douleurs lombaires et nous mettons en place des cliniques musculosquelettiques multidisciplinaires qui intègrent les principes du Stepped Care. Avant de décrire les 2 prochaines étapes du Stepped Care Model, Derek, pourriez-vous nous expliquer pourquoi vous êtes venu à Sainte-Anne?
Merci, Regina. Moi, je suis devenu client à Sainte-Anne suite à ma libération en 2011. J'étais basé à Halifax et j'ai déménagé à Sherbrooke. J'ai rencontré un groupe de vétérans et qui voyaient que je souffrais, puis je n'avais pas de service à Sherbrooke. Alors, avec ma gestionnaire de cas, ils m'ont amené à Sainte-Anne, puis c'est là que j'ai commencé tous mes services pour ma douleur chronique, pour la santé mentale, toutes les capsules et tout. Merci.
Donc, comme Derek l'a bien expliqué, en cas de réponse sous-optimale au traitement ou s'il existe certaines comorbidités sous-jacentes à la douleur, telles qu'une dépression grave, l'abus de substances, nous passons à l'étape 2 de notre modèle de soins qui implique des ressources supplémentaires, des évaluations complètes et un traitement en collaboration avec des équipes multidisciplinaires et des consultations avec des spécialistes des disciplines appropriées. Dans l'étape 2 de notre réseau, nous avons la clinique de gestion de la douleur et des traumatismes liés au stress opérationnel à Sainte-Anne-de-Bellevue, qui est uniquement au service des anciens combattants. La clinique offre une évaluation interdisciplinaire afin d'établir un plan de soins qui implique un travail individuel ou en groupe avec plusieurs professionnels tels qu'un physiothérapeute, un ergothérapeute, un thérapeute en réadaptation physique, un psychologue, un psychiatre et un conseiller en polytoxicomanie et en toxicomanie. Par exemple, la psychoéducation et la psychothérapie sont utilisées pour travailler sur des défis tels que les stratégies d'adaptation, la gestion du stress, l'adhésion au traitement, la gestion du sommeil, la nutrition, la gestion des substances et la désintoxication. Lorsque les professionnels des soins primaires ou secondaires ne sont pas en mesure de traiter de manière satisfaisante la douleur chronique ou qu'il y a lieu de s'inquiéter de la toxicomanie, ils peuvent orienter les personnes nécessitant des diagnostics et des interventions très avancées et des services spécialisés dans la douleur chronique vers le secteur tertiaire des soins. C'est l'étape 3. Dans l'étape 3, nous disposons d'une clinique interdisciplinaire de gestion de la douleur dans le réseau intégré de McGill, qui regroupe des médecins spécialistes de la douleur, des neurochirurgiens, des anesthésistes, des rhumatologues, des physiatres, des radiologues interventionnels, des psychiatres, des infirmières, un physiothérapeute, des psychologues, un spécialiste de toxicomanie et un travailleur social. Et ils offrent une variété de traitements multimodaux avancés tels que les procédures guidées par l'imagerie, les blocs, les thérapies physiques individuelles et les approches de santé comportementale. Nous disposons également d'un programme interdisciplinaire intensif de 9 à 12 semaines de réhabilitation et d'autogestion de la douleur chronique. Derek, aimeriez-vous décrire votre parcours à Sainte-Anne pour illustrer les caractéristiques spécifiques des programmes?
Merci, Regina. Sur mon aspect, avec mon trajet à Sainte-Anne, on est pris en charge complètement pour notre douleur chronique, notre santé mentale. La douleur chronique, il y a des cours de yoga, on rencontre le physiatre, sont très avancés, très humains, ils prennent soin des vétérans. Moi, je suis très content d'être un client là. Puis, j'ai pas besoin de me déplacer à 50 000 places. Là. C'est un endroit pour tous mes besoins. Merci.
Merci, Derek. Donc, comme tu as dit, il est important de noter qu'un modèle de soins tel que Stepped Care encourage une approche multidisciplinaire pour la douleur chronique en utilisant une ou plusieurs modalités de traitement à travers les 3 étapes. Plus précisément, il s'agit des 5 grandes catégories de traitement: médicaments, thérapie physique, approche interventionnelle, approche comportementale et santé complémentaire et intégrative. Des exemples sont énumérés dans le diagramme. Dans chacune des 5 grandes catégories, les traitements varient en complexité et certains traitements ne sont proposés qu'à la 2e ou 3e étape. Par exemple, la neuromodulation ne sera proposée qu'à l'étape 3. Toutes les modalités intègrent des outils d'éducation et d'autogestion et peuvent être dispensées en personne ou en ligne et soutenues par diverses applications mobiles. Le choix de la modalité dépend réellement du diagnostic de la douleur, des mécanismes de la douleur et des comorbidités connexes, surtout des préférences, des besoins et des croyances des personnes vivant avec la douleur chronique. Derek, pourriez-vous décrire votre parcours à Sainte-Anne qui illustrera les caractéristiques spécifiques des programmes et la façon dont le programme vous a aidé?
Le programme m'a aidé beaucoup. Ça m'aide à tous les jours. Ça me donne les outils pour comprendre mes aspects de ma douleur qui est relié avec le stress ou peu importe. Moindrement, quand que je souffre, j'ai une explication pourquoi. Et ça, avec l'éducation, puis tout le travail de l'équipe à Sainte-Anne qui m'ont vraiment aidé à découvrir tout ça.
Merci. Donc, enfin, si nos programmes ont eu des résultats positifs, nous pouvons encore améliorer l'accès et la qualité des soins offerts. Afin de garantir que les personnes souffrant de douleur soient vues au bon niveau et au bon moment, nous intégrons des outils au modèle Stepped Care pour identifier les facteurs de risque qui faciliteront l'accès aux soins spécialisés plus rapidement. Derek, aurais-tu quelques dernières réflexions?
Oui, merci. Ma dernière réflexion, c'est que vous n'êtes pas tout seul. Il y a des services disponibles pour nous aider. Tout est possible. Restez pas enfermés chez vous. Les vétérans, on prend soin de nous autres, puis pour nous aider, et il y a des possibilités. Merci beaucoup de m'avoir ici.
Merci, Derek. C'est un grand honneur de travailler avec toi et le Centre d'excellence pour la douleur chronique des anciens combattants canadiens afin d'améliorer le bien-être et la qualité de vie des anciens combattants et de leurs familles. Merci.
Thank you very much, Regina and Derek. On top of all the efforts we're making in finding improved ways of treating chronic pain in our veterans, you've truly shown that there is hope. Now I'll turn it over to Dr. Schoolmaker to introduce the next presenter. Eric?
Thank you, Michelle. It's my privilege to introduce a clinical leader in chronic pain management in the United States Department of Defense, Dr. Diane Flynn, a board-certified family practitioner and addiction medicine specialist. She's a former U.S. Army physician with deployment experience in both Kuwait and Afghanistan. She served as the chair of the Department of Family Medicine and subsequently the chair of the Department of Pain Management at one of our larger medical centers, Madigan Army Medical Center in Fort Lewis, Washington, in Tacoma. She's been a pivotal leader in the U.S. Department of Defense in advancing workable operational solutions for chronic pain management by building patient-centered, multidisciplinary teams to tailor care for the needs of the individual. Thank you for being with us today, Dr. Flynn.
Thank you, General Schoolmaker. It's a pleasure to be here today. At the end of today's presentation, participants will be able to explain the concept of the step care model of pain management, list 3 self-management approaches that are effective for chronic pain management, and list at least 3 types of pain therapies that do not involve medications, injections, or surgeries. The step care model of pain management was spearheaded by the United States Veterans Health Administration and in 2010 was endorsed by the DoD VA Pain Management Task Force, which was convened by General Schoolmaker when he was the Army Surgeon General. In 2018, the Defense Health Agency reaffirmed the step care model of pain management for the military health system. The step care model is summarized on this graphic. You can think of this model as layers of an onion. The outermost layer is self-management, shown in beige, and it's the foundation of pain management. Self-management pertains to effective approaches that people living with pain can do on their own on a regular basis to manage pain. And in a moment, I'll discuss some of these approaches. Simply stated, the model asserts that for pain conditions that are more complex, more specialized care is recommended. When self-management approaches are insufficient, the next step is seeking care from a primary care clinician in the patient-centered medical home. In the presence of certain factors such as severe pain, mood disorders, need for referrals to other clinicians, use of the emergency room, certain sleep conditions, opioid use, poor response to primary care management, functional limitations, or other medication concerns, the primary care clinician will involve other members of the primary care team, referred to as the medical neighborhood. This may include a behavioral health provider, clinical pharmacist, physical therapist, care coordinator, or consultation with the pain specialty team through telementoring. If response to treatment is insufficient, or if there's a concern for substance use disorder, the individual may be referred to a pain specialty clinic. Several medical centers in the U.S. military health system have established interdisciplinary pain management centers staffed by pain specialty physicians, a nurse case manager, clinical pharmacist, health psychologist, addiction specialist, physical therapist, and acupuncturist. Some also include an occupational therapist, chiropractor, yoga therapist, and massage therapist. When pain intensity is better controlled, mood is improved, referrals are completed, medication risk is reduced, and function is improved, the individual returns to primary care and self-management. Another way to view the stepped care model is shown in this graphic, and I'll go through each component of the graphic. But the important point I want to make is that for most people living with pain, there's not one single treatment approach that provides optimal response. Typically, a combination of treatment approaches works best. Some of the approaches listed on this graphic are effective for some people, but we don't know which will be most effective for any given individual. Therefore, I encourage those with pain to have an open mind and try as many as possible to determine the most effective combination of therapies. Self-management approaches that can be effective include establishing treatment goals that are aligned with each person's values, Education about pain can help. For example, this graphic is directed at education about pain. Physical movement is a critical component of pain management. Exercise is among the most consistently beneficial approaches to chronic pain. And no single type of exercise has been proven to be superior to another. So it's recommended to select a type of exercise that any given person is motivated to engage in. Behavioral health approaches that can be effective include cognitive behavioral therapy, mindfulness, meditation, progressive muscle relaxation, and biofeedback. Physical therapy and occupational therapy are often effective and can help those with pain to develop a home exercise program. Complementary and integrative therapies such as chiropractic or osteopathic manipulation, acupuncture, yoga, and massage can be effective. Interdisciplinary programs that combine self-management, behavioral health approaches, and physical or occupational therapy can be a good option when less intensive approaches have not provided sufficient relief. Medications such as non-steroidal anti-inflammatory medications, acetaminophen, and prescription medications may be effective. And choice of medication is based on the specific pain condition and other common conditions that may be present. This table shows medications that are recommended and not recommended for common chronic pain conditions. The yellow portion of the table shows the most common pain conditions we see in our interdisciplinary pain management center: acute low back pain, chronic low back pain, neuropathic or nerve pain, osteoarthritis of the hip and knee, and fibromyalgia. The right side of the table shows common conditions that may not have brought people to our clinic, but they may have in addition to the problem they were referred for, such as insomnia, headache, both migraine and tension type headache, depression, anxiety, and PTSD. The left side of the table lists medications commonly used, both topical medications that are placed on the skin and oral medications that are taken in pill or capsule form. The green circles and check marks are medications proven to be effective for selected conditions, and the red circles and check marks are those proven not to be effective or the harms outweigh any benefit. For example, the most common condition we see in our clinic is chronic low back pain. There are no topical medications that have been proven to be effective for low back pain. Oral medications that are effective for some people with chronic low back pain are non-steroidal anti-inflammatory medications like ibuprofen or naproxen. Acetaminophen, on the other hand, has been proven not to be effective for low back pain, so we don't recommend it. Duloxetine is a prescription medication that's taken once daily that can reduce low back pain. Tramadol, which is a weak opioid, may also help, but we rarely use it in active duty service members because it can interfere with military deployments. Muscle relaxants may help for acute low back pain, but are not effective for chronic low back pain. Oral steroids like prednisone are not effective. Benzodiazepines like Valium are also not effective and have significant risk. Opioids are not more effective than safer medications and have significant risks, so are not recommended. For another example, consider the person who has chronic low back pain as well as arthritis of the hip or knee and depression. The table can be used to identify a medication with potential benefit for all three conditions. You can see that duloxetine is effective for several common conditions. The other therapies that can provide relief for some chronic pain conditions include therapeutic injections and, in some cases, surgery. Again, for most people living with pain, a combination of these therapies is the best approach. The key takeaways of this presentation are: the step care model was adopted by the U.S. military health system. Self-management is the foundation. And the more complex the pain condition, the greater the intensity of care. And for most individuals living with pain, a multimodal approach is recommended. Thank you.
Thank you for a very clear and informative presentation, Diane, and to all of our presenters. I'd now like to ask all of our speakers to rejoin Lieutenant General Massonov and me for a live question and answer period. The format is going to be that I'll pose a question in English, and after an answer in English, Lieutenant General Massonov will represent the question in French for our French-speaking audience, to then be answered in French. So Dr. Flynn, we're going to start with you. Our first issue is one that you emphasized in your talk, and that is that each of our Canadian veteran guests, including Derek today, has emphasized the importance of the patient's ownership of his or her own pain, as well as to gain the tools and the skills to ameliorate it, to figuratively look at their pain in the eye and take possession of it. Can you comment on your perspective of this notion and your experience and practice around it?
Yes, thank you, Lieutenant General Schoolmaker. You know, I think a lot of times when people living with pain go to physicians or their healthcare providers, they're looking for a cure. They're hoping that their condition can be fixed. And healthcare providers like to be fixers. We like when someone comes to us with where we can offer a fix. They come to us with strep throat and we can offer a cure with an antibiotic, or a surgeon likes to be able to offer a cure to someone who comes with an inflamed appendix by removing the appendix and fixing the problem. But unfortunately, like most chronic conditions like diabetes or asthma, the management of chronic pain is typically not resolved with one simple fix. It requires a combination of therapies, and it requires time and effort on the part of the person who's living with pain. The management of chronic pain requires change in behavior, a change in lifestyle. It requires, exercising, even on those bad pain days. It requires making time for mindfulness or yoga or whatever it is that's been shown to be helpful for an individual, even on the busy days. Several years ago, I attended a class for US veterans that was being led by Tony Mariano, a pain psychologist from the the Seattle VA hospital. And he was talking about how his team was there to support the veterans more in the role of a coach than as a fixer. And the way Tony phrased it was, we will meet you 49% of the way. And by that, he meant the majority of the time and effort of pain management really fell to the veterans. Thank you.
Alors, je vais répéter la question en français pour Patricia, Regina et Derek. Tous les vétérans qui ont participé à nos webinaires ont réitéré l'importance pour le vétéran ou la vétéran de s'approprier leur propre douleur, de lui faire pleinement face. Pouvez-vous commenter cet aspect du traitement dans votre expérience et votre pratique? Premièrement, on va commencer par le Dr Poulin, puis Regina et enfin Derek.
Oui, absolument. En effet, la relation que l'on entretient avec la douleur va avoir un effet sur cette douleur-là, sur la façon dont elle la gère, sur les émotions qu'on vit en relation avec elle, sur les pensées qu'on a aussi en relation avec elle. Et tout ça va avoir aussi un effet sur notre douleur et notre qualité de vie. Comme Diane a mentionné, l'idée que la gestion de la douleur chronique, pour quelqu'un qui vient dans notre clinique, on va les rencontrer à 49% du chemin, et ça veut dire que 51% du chemin vient de la personne qui souffre avec la douleur chronique. Donc, la douleur chronique demande beaucoup d'une personne. On doit s'engager à faire des différentes activités pour la gérer. Des fois, il faut se retenir d'en faire trop et vraiment être capable de modérer nos activités. Des fois, il faut aussi être capable de s'engager dans des exercices, dans l'auto-soin, même les jours où est-ce que ça ne nous tente pas, où est-ce que ça va très mal et peut-être où est-ce qu'on est dans une crise de douleur assez aiguë. Donc, les professionnels de la santé, on aime vraiment guérir. On aimerait bien avoir la baguette magique qui pourrait nous permettre de guérir la douleur chronique, mais malgré les recherches qui s'accélèrent au niveau du traitement de la douleur chronique, on n'en est pas là. Donc, on doit vraiment s'en tenir à beaucoup d'autogestion et d'investissement de la part des vétérans qui souffrent de douleur et pour atteindre la meilleure qualité de vie possible. Merci.
Merci, Regina.
Oui, donc je suis tout à fait d'accord avec Dr. Poulin et Dr. Flynn et j'aimerais juste rajouter donc qu'est-ce qui est important, c'est que dans tous les paliers de soins qu'on a vus dans le modèle par étape, que les professionnels de la santé intègrent cet aspect d'autogestion dans chaque rencontre avec les vétérans ou les personnes souffrant de douleurs chroniques. Donc, l'idée, c'est vraiment d'avoir une prise de décision partagée et un certain ownership du vétéran et également d'établir des objectifs soit liés à la pharmacothérapie ou à la thérapie cognitive ou à l'exercice et d'établir une fréquence avec laquelle on peut faire des suivis ou des rappels avec les vétérans quelques fois par semaine pour s'assurer que tout va bien. Et notre rôle devient plutôt un rôle de coach pour les soutenir dans la mise en place de ces plans d'action avec des objectifs qu'ils auront déterminés. Donc,
Eric, peux-tu rajouter quelque chose?
Oui, bonjour. Ça, c'est une bonne question. Puis, de mon côté, je vais vous donner un petit exemple. Moi, je suis un ex-cuisinier. J'aime ça faire des sushis. Puis maintenant, avec toutes mes douleurs chroniques, je ne suis pas capable de faire mes sushis de A à Z comme je faisais avant quand j'étais militaire. Si je le faisais, bien là, je souffrais pendant des jours après. Mais à la clinique de la douleur à Sainte-Anne, qu'est-ce qu'ils m'ont appris? C'est que je suis capable d'étirer la façon que je fais mes sushis. Fait, le matin, je vais faire cuire mon riz. Je prends un break. Je vais couper mes légumes. Je prends un break. Une fois que c'est tout cuit, là, je commence à rouler. Je prends un break. Je mets ça dans le frigidaire. Là, quand la visite arrive, je commence à sortir mes choses tranquillement. Je commence à préparer mes choses tranquillement. Je n'ai pas le choix. Tout ce que je fais aujourd'hui, il faut que j'y pense. Sinon, je vais souffrir. Puis Sainte-Anne, ils m'ont donné les outils pour le faire. Puis nous, les ex-militaires, on est très têtus. T'sais, ils vont nous donner un exercice ou de quoi à faire, bien, on a tendance à en faire trop, puis après ça, on souffre. Fait que c'est important de le faire, de le mettre en étapes, puis tout faire ça d'une séquence. Puis la douleur chronique, elle va toujours être là. C'est mon petit jumeau qui est à côté de moi, qui me parle, puis il s'agit de trouver des façons de le gérer.
Merci, Eric. Merci, Derek. Merci. Eric, back to you.
Dr. Flynn, thank you, Michelle. Dr. Flynn, the step care model of comprehensive pain care being adopted both by the U.S. Department of Veterans Affairs and the Department of Defense, and highlighted today by both of our Canadian colleagues and by Derek, who's received services through it, rests first on self-care, as we've talked about, and then on primary care. Of course, we all agree, I think, and we'll emphasize that we want to deliver care at the appropriate level, at the appropriate time. Access to primary care providers who are trained and competent and confident about managing pain at their level appears to be a key element, though. And it's not simply referring patients to the highest specialized level of pain clinic without assessing and attempting management, if appropriate. Could you please address the need for good access to primary care and to overcoming the obstacles that are presented by the remoteness of many of our US and certainly our Canadian patients? And then how do we use information technology enablers such as the ECHO program or telehealth to assist in that?
Yes, thank you, Lieutenant General Schoonmaker. Yes, primary care providers are well suited to provide comprehensive pain management. They often are the providers who know their patients best. They know their patients' families best. They know their community resources and when the resources are challenged. They're well trained to identify and treat some of the conditions that Dr. Poulin mentioned that often occur with pain, such as insomnia and depression, and PTSD. There are certainly times when the primary care provider will appropriately want to get other health professionals involved in a patient's pain management plan, such as physical therapists or psychologists or interventional physicians. But the primary care providers are often in a good position to coordinate this care best. Now, it is critical that primary care providers have the skills and support to care for people with pain. And in the US, VA, and DoD systems, you mentioned we have a telementoring program called ECHO, which is short for Extension for Community Healthcare Outcomes. And this is a weekly telementoring VTC where pain specialty teams at military centers reach out to primary care teams in their region. So in our region, for example, we're based in the Tacoma, Washington area. We co-facilitate our weekly ECHO with the Seattle VA. And our outreach goes to Bassett, all the way in Fairbanks in Alaska, and throughout Washington State. And in each of these sessions, it's a 90-minute virtual session. The first part of each session is dedicated to a didactic, so an educational topic on a pain-related topic. And after the didactic session of the ECHO, we proceed to case-based teachings. And this is where primary care providers throughout our region will discuss their patients to our interdisciplinary teams. So no names are used, so we're protecting the identity of the veteran, but the primary care provider will tell us the veteran or the soldier's or the family member's story and ask specific questions about how to manage this patient's pain. And the beauty of this approach is not only does that provider learn how to manage that patient, but all of the providers who are listening in are learning things that they can apply to patients who they see. Now, I'm a family physician, and most of my career was spent in primary care. So when I transitioned about 10 years ago to pain management, much of what I learned was through ECHO. So I'm a true believer in this approach. Thank you.
Merci beaucoup. En fait, si je pose la même question en français rapidement, parce qu'on a juste quelques minutes, en gros, c'est l'utilisation des moyens technologiques pour aider le traitement de la douleur. Et on va commencer premièrement par Regina, ensuite Patricia en quelques mots et Derek, si vous avez quelque chose à rajouter. Regina?
Oui, donc rapidement, c'est que souvent en première ligne, les médecins de famille n'ont pas accès aux ressources requises pour la gestion interdisciplinaire de la douleur chronique. Alors, on met en place un programme, en fait, il y a deux modalités. Une, c'est la consultation numérique. Donc, les médecins de famille peuvent rapidement poser une question à un spécialiste pour confirmer soit un diagnostic ou un plan de traitement. Et ceci permet à la personne vivant avec la douleur chronique de rester avec son médecin de famille pour la suite des traitements. Et il y a également le programme ECHO, donc qui est une discussion de cas qui se fait sur un patient qui n'est pas identifié. Et donc, c'est la première ligne qui présente le cas à une équipe interdisciplinaire de troisième ligne. Et la première partie est 10 minutes de session éducative et la suite est la discussion de cas. Donc, tous les professionnels autour de la table essayent d'identifier les problématiques et le meilleur plan de traitement pour ce patient. Et par la suite, il y a un suivi qui est fait avec le médecin de famille. Donc, encore là, le patient pourra rester, n'a pas à voyager plusieurs kilomètres ou centaines de kilomètres pour obtenir un plan de traitement interdisciplinaire.
Merci beaucoup, Regina. Patricia, voulez-vous rajouter quelque chose?
Oui, je voudrais mentionner aussi que présentement, il y a un consortium de partenaires qui sont en train de se mobiliser pour développer un portail national sur la gestion de la douleur chronique qui va ressembler à l'espace mieux-être qui a été subventionné par Santé Canada, qui offre des services à tous les gens qui ont des problèmes ou des challenges ou des défis au niveau de la santé mentale ou la consommation de substances au Canada, 24 heures sur 24, utilisant une approche par palier. Donc, pour aussi augmenter la capacité à servir les vétérans et tous les Canadiens qui vivent avec la douleur chronique. Je pense.
Merci. Merci, Patricia. Derek, un 10 secondes.
Ben, moi, je suis capable. Vous êtes capable. Vous n'êtes pas tout seul. C'est aller chercher de l'aide.
Merci beaucoup. Eric, back to you for closing comments.
Thank you. That's all the time we really have for our session today. I want to thank all the panel for their informative and encouraging comments. I want to thank Derek for joining us. Certainly the Chronic Pain Center of Excellence under Dr. Zacharias and our NHL colleagues. We'll conclude our series of weekly webinars next week. And with that, I'll pass it off to Lieutenant General Massaneuf.
Thanks very much. Ceci conclut notre troisième dans la série de 4 webinaires. Merci à tous pour votre présence et vos questions. Merci au Centre d'excellence sur la douleur chronique d'organiser ces webinaires. Nous espérons qu'ils vous apportent de l'aide et de l'espoir dans le traitement de la douleur chronique. Et vous comprenez maintenant que nous privilégions une approche multidisciplinaire dans le traitement de la douleur et une approche basée sur le dialogue entre le clinicien et le vétéran lui ou elle-même. We hope this shared dialogue between the clinician and the veteran will provide what's perhaps the most important thing, hope. I also want to highlight the excellent collaboration with our U.S. colleagues. It's a privilege and an honor to collaborate on this project in order to help veterans from both countries. Je vous invite à consulter notre site web et à nous adresser tout autre commentaire. Je vous rappelle que notre prochain et dernier webinaire est dans exactement une semaine. Thank you for your presence at this third webinar and for your thoughtful questions. And remember, our fourth and last webinar will be 1 week from now. In the meantime, I invite you to go to the Center of Excellence for Chronic Pain website and send us any comments or questions you might have. À la prochaine.